Welcome everyone to another episode of Project Podcast presented by Project Insulin. Today I have Rachel with me. Rachel and I don't know each other. We do now. We spent the last 15 minutes just chatting. But Rachel and I didn't know each other before this. This is one of the few interviews where I am coming in without any background info. So for me and the viewers, Rachel, can you tell us a little bit about yourself?
Yes. My name is Rachel. I am based in Atlanta, Georgia. I am also a travel nurse, so you'll see me all over the place. I am also a board certified diabetes care and education specialist. We call them CDCESs now, which is impossible to say. It was previously a CDE, but we're trying to be a little bit fancier now. So I work mainly as a diabetes educator or an endocrinology nurse. And I have also been living with diabetes for 27 years. So I have a lot of professional experience as well as quite a bit of lived in experience in the diabetes space. So I'm excited to be here.
Yeah, I'm now excited to ask you questions about 27 years living with diabetes and also working in the space. So excited to get into that, but let's rewind first. Tell us about how you were diagnosed. How old were you? What happened?
Yeah, so everyone's gonna know how old I am. I was 5 years old. My symptoms started out like on a camping trip. It's a classic Halverson camping trip story, simply because I was holding a can of Mountain Dew in my hand the whole time because I was so stinking thirsty. And of course, nothing like pounding back full sugar Mountain Dew while you're on your way into DKA. But yes, thankfully I had some family members around me. My uncle's a doctor, his wife is a nurse, her sister is a nurse. And they were like, Rachel should go to the doctor. So my mom took me there, and sure enough, I honestly don't remember a lot about. Everybody has a diversity and knows what their lab values were. The only thing I really know was it was like during the summertime, and I was very fortunate. I must have caught it very early. Again, speaking to my own privilege in that regard, I had a lot of good doctors and a good hospital system in Atlanta that I was able to get to, that I know a lot of my friends didn't quite have the same experience. So I didn't have to be admitted to the ICU for DKA. I believe I was just like just casually in the 500s, but it could get quite a bit higher than that. But I was really lucky to have caught it so early, where my symptoms were pretty minimal and the hospitalization wasn't particularly bad or traumatizing. I think too, when you're diagnosed so young, I had much less of a traumatic diagnosis experience as opposed to maybe somebody that has gotten it a little bit older, or when your frontal lobe has been fully developed and you're ready for some really traumatizing experiences. I do very specifically remember the feeling like a loss of control, though, even as a 5-year-old. That was very prevalent in my brain. And I know I went to the nurses and I said, you're going to teach me how to poke my fingers because I don't like when you do it, and I want you to teach me how to inject because my mom stinks at it. And so from that point on, I was a very independent diabetes kind of person, for better, for worse, mostly for worse as time went on. But that was a little bit of how it came to be. And I think I tell everybody I was diagnosed one time and then maybe a second time in nursing school when I truly learned more about what diabetes really was, and that my 5-year-old perspective was no longer something I should be basing my knowledge off of. So, yeah, that first part, not too insane, but pretty classic younger diagnosis story.
So you are officially the youngest person, or youngest diagnosis age.
Yeah.
And 2 in a row in Atlanta, actually. I also had a relatively good experience because of the doctors being really good in Atlanta. I don't know anything about Atlanta, but I do know now that if you need to go to the hospital,
you're going to get diagnosed.
It's a good place to go. And so it's really interesting. You talked about the loss of control as a 5-year-old is like a very deep emotional thing to really hold on to and remember that piece, especially who remembers anything from when you're 5. But could you walk us through those early few years what it was like. Generally, I've heard being self-conscious about having to prick your finger and check things all the time. And you're growing into a person. So it's like your identity and then like the identity of there's Rachel and there's Rachel with diabetes. And it's like, how did that all happen? Yeah.
From having now talked to a lot of patients that are getting diagnosed later in life, it is such an interesting difference. Like, kids really will cry for a few days and then I'm like, this is just how it's gonna be. Because I guess your sense of self is it's changing so much. It wasn't particularly freaky. And I feel very grateful for that. Again, because I work so much with people that have been diagnosed later in life. I can only imagine how wild that is to receive a diabetes diagnosis and change your life completely. Whereas I honestly do not remember a thing prior to that. I feel like I remember being annoyed that the nurses and my parents were so bad at poking my finger. I wanted to do it myself. But for the most part, I just like slid right into it. I do want to mention as well, since it sounds like I'm one of the younger diagnoses, we had some weird stuff. So there were no CGMs. There were just these blood glucometers that took really large globs of blood. So that was 0 amounts of blood. It took quite a long time, maybe like 3 to 5 minutes for it to give you a result. You were also on NPH and regular insulin, which still exists. It's the Walmart insulin, as we now are referring to it as, or the insulin you give your dog or cat when they get a diagnosis. And this stuff was nasty because NPH was an intermediate insulin that took eventually Lantus and Tresiba replaced that. So you had to take it twice a day. It lasted 12 hours. So you take it in the morning and then you take it around dinner time. And then regular insulin was what we used in place of the rapid acting insulins we have now, like Novolog, NovaRapid, Humalog, Fiasp, all that good stuff. And instead of a 15-minute pre-bolus, you needed like a 30-minute pre-bolus. So there was definitely a lot more. I felt like there was a lot more burden at that time for me than there is now, which it probably sounds strange to somebody that was diagnosed later. What are you talking about? And I totally agree. It still sucks. But comparatively, it was just like an interesting. I know that definitely took its toll, was feeling like I had to wait to eat so much longer. Did make me feel pretty self-conscious as a child because nobody else was doing that. I was fortunate enough to go to a diabetes camp, summer camp. So that's helpful to see that other kids are experiencing the same thing. But I was, again, just very fortunate to have a really good support system and family and friends that didn't make me feel othered very often. So it was a reasonable time to grow up. And then I got to see all the cool, like, we've gone through so many new advances in medication and technology since then. So it's been like really wild to get to experience all that. I was like one of the first adopters for a lot of different insulin pumps and things. So
yeah,
it's cool.
Yeah, so that is really cool. So then you teased that when you went to nursing school, you get re-diagnosed almost. I'm curious, maybe tell us a little bit about where technology was at that point, and then B, tell us a bit more about what about that time? What did you learn? What kind of led to you feeling that it was like a re-diagnosis?
Initially, I was not taking care of diabetes pretty much at all because I don't know if somebody forgot to re-educate me as I grew up or I wasn't paying attention, but I was still thinking about like the survival skill version of diabetes, which was keep it in range and then just don't die. That was literally how I looked at diabetes. And there was a lot of horrible thoughts about we differentiated so much between type 1 and type 2. It was like such a big thing, even more so than it is now. Like JDRF really pushed that for a long time. Like, you guys are really different. You can do whatever you want. You're not at risk for all of these things. So I thought I was just a very different kind of diabetes, even though I had people in my family that were experiencing complications and the issues that arise with maybe not keeping yourself in a certain range. So that was how I grew up for a long time, up until like mid 20s probably, that I finally was like, I was in a high risk pregnancy diagnosed nursing class very specifically. And it was when they took away, they just said people with diabetes and then put down all of the complications in pregnancy. And I was like, oh my God. Oh, I couldn't believe, I was like, wait, it was never, it's all people with diabetes are at risk. And I felt so stupid again, because I like, it took me until getting like a medical degree basically to realize what my diagnosis meant. So that was much later. I was probably, when did I go to nursing school? It was in like 2018. So I was like 26 or 27. I was on, and this was pretty modern stuff. I hadn't yet discovered continuous glucose monitors, but I had started to pay a little bit more attention. And especially after realizing that I needed to get it together to a certain, maybe a little bit more than I was previously. But yeah, that was really shocking. And then throughout my school, like learning, nursing is so weird. It really is a trade. So I feel like I learned a lot on the job. I learned a lot on the job as a diabetes educator. And it was like just reading through stuff or hearing from other educators what the vibes are. And I was learning more about, it wasn't just that you replace insulin, like you're also GLP-1 resistant. You're also not producing an entire hormone called amylin, which we don't replace unless you want to buy really expensive medication that doesn't work very well and makes your tummy hurt. So again, just like multiple, it was just like really discovering how disabled I was as I got older. So sometimes I can relate a little bit to my later diabetes friends, because I know what it feels like to see that loss of function and like really understand it finally. Yeah.
Yeah, like really became tangible.
Yeah.
Yeah, that's very interesting. It's like, now I get why you say it was like a second diagnosis.
Mm-hmm.
Really, like, yeah. Now it's really interesting. You mentioned, what was it called? Amylin?
Yeah.
So also the other Atlanta person brought this up, and this is something that I'd never heard of before. Again, I don't have diabetes. I didn't go through that whole experience and learn. I'm learning on the fly as we move forward with Project Insulin and stuff. But I'd never even heard. I was like, diabetes, lack of insulin.
Yeah.
Pancreas stops working. Pancreas makes insulin. Great, easy enough. And now it's no. There's all these other things. I feel like it's something Another thing I've heard is that doctors don't tell you about all the complications. Not always. As a 5-year-old, fair enough. But between 5 and 27 is a pretty long time.
Yeah, it would have been nice maybe if somebody had checked in. What is your
But yeah, like I'm curious if you could talk to a little bit more of some of the other pieces of diabetes, like amylin, or like what else happens when you have diabetes? Like what is happening in your body?
Yeah, and this will likely ruin a lot of people's lives, because I feel like it ruined mine a little bit. But yeah, it's hard. It's like, how do I struggle with what kind of information do I give people that's not going to truly terrify them when they're first diagnosed? They're already so terrified. And then it's like, when do we start bringing these things up? But so I don't completely know the answer to that. Yes, buckle yourself up. But
let me try again. Let me. Okay, you're a nurse. I'm a patient. I recently got diagnosed, let's say within the last 6 months. What is the information you're telling me? And then maybe after that, we will do another version if it's been like 10 years.
When you're first diagnosed, they do give you survival skills. So it makes sense that you would not learn this kind of stuff right off the bat, because we want to make sure, especially if you're in the hospital, I'm not going to go over diabetes pathophysiology with you, because I just need to make sure you know what the range is and like how to treat a low and then how to take your insulin. That is majority of the information I'm going to tell you, especially if you're receiving a lot of that education in the hospital. And we call those survival skills in diabetes education land. Now, the thing about diabetes education is it's very freestyle, which is terrible. And I've actually talked to some people about this where thankfully educators are generally, they enjoy educating. So a lot of the training they do, and I've done a lot of classes in motivational interviewing, which is a way of teaching and coaching. That's not required though. So if somebody has like a diabetes care and education specialist label, it's like they're not usually there is a little bit of guidance there, but it's whether that person knows it or not about when do I start, what kind of information do I give somebody during 2 years later or 5 years later.
Mm-hmm.
Your results will definitely vary. But I think, again, depending on what this person's age is and what their diagnosis is, it is important to go over the fact that beta cells do more than just produce insulin, and your beta cells are now destroyed. One of those hormones was amylin. So your body no longer produces amylin. So one of the reasons why your blood sugars go so high after you eat is not just because you don't have insulin. It is because you don't have amylin, which is what allows the stomach to hold on to food for a longer period of time. So when you have diabetes, you're going to be hungry. There's a lot of talk about weight gain and things like that. And it could be because of increase in insulin, but it could also be because you're hungry, which is a normal, and it doesn't mean I don't want you to feed yourself, but that is something that you could totally experience because you've just lost 2 different kinds of hormones. And then on top of that, we don't know the true extent of it, but your liver puts out an inappropriate amount of glucagon. And when I'm teaching you survival skills, you just know that glucagon is what saves you from a severe low blood sugar. But it's also your liver, your alpha cells, which did not get destroyed, are still working to produce glucagon, but it does it in a way we don't like. So instead of producing it when you're low, when it needs to be produced, it produces it at very inappropriate times, like after you eat. So again, there are all these things that, again, you could take the same amount of insulin every single day for the same thing, and you would have different results because of these funky hormones that are doing weird things. So glucagon is one of them. Amylin is another. GLP-1 is another hormone that we know is not working efficiently or correctly in people with type 1 diabetes and the other types of diabetes. So that being said, it makes diabetes a lot harder than we advertise. Like, it's not just about taking the right dose and counting the carbs correctly. It's really, there's not a lot of control around it. It's mostly influencing, and it doesn't happen the same way every single time. But I find that sometimes that is like a really uplift. It helps to know that, because then you're not constantly, what am I doing wrong? You can understand that it's just, diabetes is way more complex, and these are the tools that I have to work with, and I'm going to use them. Sometimes they're not going to work as well as I'd like, but it's not, honestly, nothing in diabetes is ever anybody's fault, ever.
Yeah.
There's just too many factors that come into play.
And honestly, like, it resonates with me, the idea of knowing, right? Like, understanding what's going on with your body, because it's like, it sucks, and hearing it is gonna suck, and hearing it after dealing with diagnosis and just like living with diabetes, it's gonna suck. But being able to understand what your body is doing or not doing it's just helpful, whether it's diabetes or anything else. But yeah, so I think that was, honestly, that was less doom and gloom than I was expecting. That was just it seemed very facts, science, not much, and your world ends because blah, blah, blah. I think you did a great job.
Well, and what it should do also, I think, you should, like I did, I went home and cried for a little bit, but then also it should get you like really fired up and pissed off, because what that is telling you is that there is more to diabetes that needs to be treated than is actually being treated. So the medications like the GLP-1s, the SGLT2s, all of these meds that possibly could help take some of the burden off of what we're experiencing, we don't have access to because of the way we have separated type 1 and type 2 diagnosis,
Yeah.
even though they are, I tell everybody diabetes is a spectrum. That is how we need to look at it, as opposed to saying it's this type and that's how it should work, because we all end up experiencing the exact same. Similarly to insulin, right? If I'm talking to somebody about how they should be pissed off about how insulin is not affordable for everybody and not accessible to everybody, the problem is we only talk about how insulin is necessary and good for people with type 1 diabetes. It is bad and not necessary for people with other types of diabetes. And this stems from a very anti-fat, anti-Black place in of itself. But what I also want you to consider, if we're just thinking from a purely very selfish place, like there are 1.7 million US adults with type 1 diabetes, which is pretty small if you think about it. There are 38.4 million people with all types of diabetes in the US. So if we all knew that we deserved medication and care and insulin or other medications, like you have now 38.4 million people that are pissed off about it. But we spend so much time separating ourselves and tearing down the other part that it's on purpose. Like they don't want everybody to organize and be upset about it. But yeah, take the depressing information I give you and let that ignite you and want to take more action, whether that's trying to get rid of that stigma for all types of diabetes or talking to other people about it, whatever that might be. It should make you mad. It's my feeling on it.
It's really interesting that you say that, because having met many people with type 1, whether it be on the podcast, social media, just in the wild, people have started telling me that they've tried out GLP-1 drugs. And it's a risque thing to say. It's, I'm like experimenting on my own. And it's not like they're taking full doses, they're taking small amounts and just trying to see, does this help? And it seems like the people who are doing this are people who are like, who understand how diabetes affects the body totally, not just, the insulin aspect. And I'm not a doctor. I'm not telling people go buy GLP-1 drugs. That is not my place. I'm here to make a generic and sell it for cheap. But it's a pattern that I've noticed, and you're bringing it up now too. So it's very interesting. And I'm curious how diabetes care evolves and what are the steps to, like, I know GLP-1s are like approved for type 2, but do you have to then go through a whole new clinical trial process? It is just interesting because like there is these paths to make people's experiences better now, like tangibly today, that we aren't really looking at. And it's just, I don't know, frustrating.
Yeah. And it all comes down to money every single time. Like anytime I tell you why this doesn't exist, it's because of money. Yeah. Why would you? Again, because we've put out this idea that people with type 1 diabetes are superior, we're thin, we're white, we have no need for any other drugs. And that's what these GLP-1s have gotten as well, is that they're for fat people that they're taking the easy way out. And it's just like all this nasty, horrible stuff. And we continue to perpetuate that as people with type 1 diabetes. I've done it growing up, and I'm sure little microaggressions still think like that. It's something that you really have to consider. And it's like, why would they spend money on clinical trials for this group of people that we've deemed angelic and superior and not in need of that? Also, there's only 1.7 million of us. They're not going to make money off of that. Now, if you got rid of all the types, and again, we were all in need of medication, now you have a ton of people that A, they can make money off of, and then B, that deserve insulin and GLP-1s and SGLT2s and all of these meds, and they deserve access to them, and they deserve it to be affordable. Yeah. So the more I've worked in diabetes, the more I'm like, that is the crutch of it. It has never been anything else. It's just this separation of the two. And there's just until we fix that, I don't have a lot of hope that I can ever convince anyone else to care about it, because
Yeah.
for messaging.
When you say it's all about money, I generally don't bring up Project Insulin during the episodes just because it's about your stories, right? And like the whole point is to share people's stories. This isn't just free advertising for me to be like, look at the cool thing we're doing. But when you bring up like this is all about money and this is a money problem. Oh yeah, I wonder, that sounds familiar.
Yeah.
That's the gist of what we did. That's why I started this. It was like, this isn't an issue. This is just like someone write me a check and I can hire people to make drug.
Yeah.
It's not hard. It literally just costs money. And it feels like an unacceptable reason. And that was like why that was what I was motivated by, was if the reason is money, that's not a reason why people should be suffering. And obviously you can like stretch that to like literally anything around like the country, around the world. But yeah, I latched onto this one. But anyway, yeah, so it resonates with me. I understand. And yeah.
But I feel that like part of diabetes education, part of what I do in diabetes education is telling my patients that, and that they should learn to advocate and they should be pissed off because and they should learn to be more inclusive and about collective liberation and how important that is, because in the end it affects their care every single time. So I don't think it's inappropriate to talk about. Obviously we're a little biased, but I think it's a huge part of the personal experience of somebody with diabetes.
Yeah, and I'm curious on the advocacy point. So it's not CDE anymore. It's a few more letters, but sorry, what is it? Okay, as a CDCES, what is the like line between education on like my health as someone, not whatever, someone with diabetes, and like advocacy? Because like it's health and it's education, and education isn't just about, yes, of course, we just talked about like learning about how the body works, but there's more to it. So I'm curious, what is the line for you? Like, where do you go from talking about this part to talking about advocacy or talking about other things with patients? Is that what you say? Clients?
Yeah. It depends on where I am. That's a fabulous question. I think I'm definitely a weirdo and there is no line for me. For maybe other educators, there is one, but only because I'm like in the trenches with people, like when they get a denial from the insurance company, or when they are starting to develop some significant insulin resistance, but they don't have the proper diagnosis to get a hold of those medications through their insurance company. And they can't pay for it out of pocket because the drug companies are upcharging very significantly in the United States. So I'm going to have that conversation with you because I want you to know that this is why you're not able to get the care that you're supposed to be getting. Because nothing is more horrifying than me having to, I literally have done like diabetes education at homeless shelters. The fact that I need to teach this person how to survive off of the food pantry staples is just unreasonable. Just because I can do that does not mean I should be doing that. I've always felt like it's part of, I need to be, I will teach you how to live without it, but I also want you to know that you don't deserve to live without it. That's not okay.
Yeah.
And here are some things we can do about it. But I do feel like at least the information and the education makes a huge difference. I've had a few when there was on both sides of things. So we've had a lot of GLP-1 shortages and then insulin shortages. And that is because there are monopolies, right? So one company is manufacturing the drug and they have 2 factories outside of the United States. So if something goes wrong or we can't get that transported over here, we are going to have a shortage. What ends up happening is people start blaming, again, the other person, or like the individual. So when we had Ozempic shortages, I would hear from patients that'd be like, I can't get it. My blood sugars are 300 or 400. This is like truly awful. And I was like, absolutely. This is terrible. And they say, I'm hearing it's because of fat people using it when they're not supposed to. And I was like, no, we're not doing that. Or I've had somebody say, I don't take insulin, so I guess I shouldn't be worried, or I shouldn't, the $35 copay cap, that doesn't really apply to me. And I say, no, it could apply to you at some point, and it should be something that you advocate for because you could need insulin in the future. So these are all things that we have to, again, we look out for each other because it could be something that we need in the future. And it is not the individual's fault. It is the pharmaceutical company's fault. And the government needs to be regulating these companies, basically. So I don't get any kickback. They all have blocked me on social media. So I don't plan on doing any brand deals with Lilly or any of those. I'm definitely not getting a job there. I have I think it's important that it's a part of education and that diabetes educators should be having that conversation with their patients when appropriate. So. Yeah.
This isn't where I thought we were going today, but I do.
Oh my God. This is why I'm not fun at parties.
No, this is a good conversation to be having. I think it's important. And you brought up the manufacturing outside of the US specifically. And that was an issue. We plan to do distribution in the US because I just assumed it'd be cheaper to ship it from here to here. But then over time, obviously making it in India, making it elsewhere is literally cheaper. But from a distribution aspect, I thought it would be cheaper. Forget how much the drug costs to make. Just distribution, I thought it'd be cheaper to make here. Funny enough, I find out later that there are states who are commissioning projects to better understand insulin distribution in case of the Suez Canal again, or like just another global supply chain collapse. And like one of the big focuses is creating manufacturing of insulin and other drugs in the US so that if that happens, we are okay, that like we are safe. And so I was like, oh, look at me planning ahead. Accidentally nailed it. But yeah, it's a very, and it's awful to hear though. Of course, get one person to blame the other person. No one has time, and no one has time to think about the larger picture and all that. That is, I'm sure this is going to come off as a very different, it's a very different conversation. Normally it's, what was it like growing up with diabetes? And you're like, nah, we're skipping all that stuff. Let me tell you.
I know. Again, this is so I don't have any friends. No, I'm just kidding. But I feel like it usually will come up in conversations that I'm having because I feel like it's an important part again of my diabetes experience, and like we were just talking about, I was on a call literally like an hour before this, and my friend can't get a hold of an insulin pump because of issues with insurance. I am having what I fear are secondary POTS symptoms at the moment. Literally, I chugged a bunch of salt water before I got on here, but I literally cannot get the diagnostics for it because I am not working for my agency currently, so I don't have appropriate insurance. That's just insane. And the fact that we just live our lives like this without bringing it up at every party and every blind date we have is just wild to me.
Yeah, the story about the pump specifically reminded me, I know someone who travels for work out of the country. And so they need their insulin in like months worth of insulin at a time. And it's called a vacation override, right? It's called a vacation override. So you go to Walgreens or CVS, wherever you get your insulin, and you're like, yeah, I got a vacation override for the drug that I need to survive. And this person, if they're not literally bawling because they're so stressed about not having the insulin they need, when they're out in a different part of the world, the pharmacist is, sorry, we didn't get the thing yet. So like, good luck.
Yeah.
And
I've had those patients call me crying and they're like, I don't know what to do. And I'm like, I don't know what to do either. It is so, and this is actually so wild as well, but a lot of the time I tell people you're actually, as long as you're not traveling within the United States, you probably are safer in regards to insulin access.
We get a lot of people tagging us when someone's, hey, I need a vial of blog, I need a vial or something. Because it's okay, people know like one day we will have insulin and can like, but it's heartbreaking to get those messages and be like, hey, we don't have it, we're not there yet. And it's what do I do? I can't just be like, hey, we have to like, there's a line because we are a nonprofit and it is scary. Like we're definitely stepping on toes, and so there is like a level of stay in line until it's time to be loud, and then go be loud. And so it is hard, and I can only imagine from the patient perspective what that all is.
No, I totally hear you. Yeah, there have been several instances where I'll probably get fired, but no, I'm just kidding. Yeah, I can't have that I can't tell you to go to a mutual aid site.
Yes, exactly.
When I'm calling from a university hospital phone. And then it's, I have this moment, I was like, maybe I should call them on my cell phone. Should we just be friends? Like, it sucks. It really does. Because, I don't think people know that's like super illegal to distribute your own prescription to others, because it is a prescription. It should be prescribed by a doctor.
So you have diabetes, you work in diabetes as a CDCES. And as a travel nurse, I'm sure like you hit it pretty frequently in that capacity as well. Like, how do you deal with all that? That is a lot of diabetes in your life, and you're like a vocal advocate. So how do you pace yourself? What is your coping? What is your whatever? Like, how do you deal with all of it?
Yeah, I don't know. It is really interesting. I wonder a lot if I'm going to burn out at some point, because as I've mentioned, I do have like attention deficit. So sometimes I'm like, is this just like a hyper focus of mine? Like I'm just okay with, and that's fine. But it's diabetes 24/7 basically, because I'm like trying to manage my own, trying to manage other people's, or teach them how to manage it. And then also just any sorts of volunteer and things I take up. So I have been shocked a little bit. So the diabetes care and education specialist framework, there are 7 healthy behaviors, and they're supposed to like healthy eating, movement, all of these sorts of things. And healthy coping is one of them, but I feel like it really does not help anybody cope at all. And again, it comes from that place of, it's strange that we just put all of this extra self-care tasks and things on people with diabetes when they've just been diagnosed with something that's fairly debilitating. People with diabetes are truly wild. I think they should be doing the same kind of stuff all the time. And travel nursing was helpful in this because I noticed that when I was working in radiation oncology, and I hadn't done anything in oncology before, and I would have follow-up visits with patients that were on chemo and on radiation. And the things they were upset about were like not being able to do the dishes or feeling so much fatigue. And I was like, yeah, you have cancer. Duh. Like, you're going to be tired. You should ask if you have access to somebody that can help you. That's great. But otherwise, just leave the dishes in there for the night, please. And it's weird that we don't really have that conversation with people that have diabetes. So for myself, that's a lot of what I follow a lot of people in the disability community, because they're way better at that, like asking for accommodations. So one of my favorite books, and I will give you links to these things as well, but it's How to Keep House While Drowning. It's written by a woman that has attention deficit, and just giving yourself permission for accommodations. So like I'm very fortunate. I'm able to get groceries delivered to me. I am not going to the grocery store after I go to work and talk about diabetes. And I don't want to, we've just talked about how to go grocery shopping. I don't want to do that myself. And that is not laziness at all. As a person with diabetes, you're much more easily fatigued than other people. And there's just a lot more going on. So it makes sense that you would ask for accommodations or get accommodations for yourself if you have access to those. How to Be Sick is another book that I really love by Tony Bernard. And it's a very much, anytime I've recommended it to my patients, some people really love it and find a lot of comfort in it. And other people are like, Rachel, what the heck? Because it's about being at peace no matter what the circumstances are. And I think find a lot of comfort in that, having such a long time with my diagnosis, just because, again, it's about sitting with discomfort and different types of exercises you can do. They're come from sort of Buddhist teachings, which I think is helpful in diabetes world, because again, there's a lot of stuff that's out of your control. And it's like, how do I cope with that? And it's not just sitting there and meditating. There's lots of different ways you can change your perspective or think about things. So I would encourage people to go to think about what disability means to you. And if that's something that you can identify as, because it helps a lot to know that there are just going to be things that you maybe can't do the same way you did previously. And that's okay. And it sucks. And there are ways to cope with it. So there's a lot of community and stuff out there. And I wish diabetes would start taking some of that and teaching that to other people, because that's what I have found most helpful for coping. And especially as somebody that sees so much diabetes throughout the day, it can be helpful to, again, have permission for accommodations, whatever that might be.
Yeah, that's a really good point about, you just have to do it all. There is no, like, diabetes is not, it's like the worst of both worlds, right? Like, you already have a chronic illness, but you're also like expected to just do everything. Like,
it's nuts.
What do you mean you're tired? What do you mean you're not feeling good?
Yeah. It's really the only time that they're in my, like, that I know there are probably other, but when you get a cancer diagnosis, it's eat what you're able to because you feel sick, or you may not be able to do the activities and exercise that you used to be able to do. Here's some ways to plan for your lowest day. But when you are given a diabetes diagnosis, you're now to monitor everything 24/7. You have to exercise more. Like, they don't give you like some fun little chair exercises unless you like complain about it like a ton. But they just give you like, you have to go from 0 to 100 with diabetes, which is so interesting to me. And I don't know why that's the default thing, when maybe in other cases of chronic illness, there's a little bit more, we teach you how to be a little bit more gentle with yourself.
Yeah. So my sister has like a rare illness as well. She has complex regional pain syndrome. I don't know if.
Yeah.
Yeah. Okay. I always pause on that, but so I've raised money and awareness for that community, and for them, it's like it's an invisible illness. It's an illness that, like, if you were walking down the street, people wouldn't know you have that illness. And I think that just like really like changes the framing as well. Like, it's hard, and I know I've seen like being sheepish about getting accommodation, because it's like this disconnect between how you feel and how you look and how you present to the outside world versus what's going on inside, and like what goes on at home. So yeah, it's just an interesting parallel that you brought up for me.
Totally. It feels uncomfortable to have to ask for those things and again, any people with like disability and diagnosis that. It's just, diabetes is definitely a weird one. And I think it comes back to the note. Here I go again. But it does a little bit. The type 1 diagnosis is really associated with the JDRF. You can still do whatever you want. Don't let diabetes stop you. And type 2 often has this idea that if you just exercise and get healthy, you'll be fine and it'll go away and you can still do whatever you want to. It's just a very ableist, internally and externally diagnosis. And I don't see that as often with other diagnoses for some reason.
Yeah. And I'm curious, since you are a nurse, and if you don't know the answer, it's fine, but I read a book. I read most of a book. I don't remember what it's called, but intertwines stress with type 2 diabetes. And it's specifically about, it's racist. Like now the angle today is racism, but in the past it was about, you're smiling like you know exactly what book I'm talking about, but I don't know what it's called.
Hold up. I have
Okay.
a feeling.
I will keep going. It starts off talking about immigrants who come to the US and how diabetes was highly associated with those immigrant groups at the time. So at one point it was Irish people, then it was the Jews, and then it was other people, then it was Latin American, and now we have Latin American and Black people are the quintessential examples or the stereotyped examples of type 2 diabetes. And the book goes out and argues that stress is what all these groups have in common because they're coming into a new place. They have to deal with all the additional stress, whatever. Could you explain that to me? The book was too far advanced for the where I was at the time when I read it. That I got it. The connection is stress and diabetes. It's not necessarily weight.
Right.
It's not necessarily all these other things, but stress seemed to be the common variable across all these groups across this 100+ years. Could you, like, if you can, explain that a little bit more, a little bit like simpler?
Eric, I'm like giggling because I'm like, oh, I love this book. Also, I recommended it to you.
Oh, it was you! Yes!
Because I think you had commented on one of my posts about it. And then I was like, yeah, it's from this book. Anyways. But I agree, it's a really heavy book.
That's so good. It was okay. Yeah. I was like explaining. I was like, man, Rachel could have been the person.
It's Diabetes: A History of Race and Disease by Arlene Touchman. Excellent book. Yeah, would recommend.
Yeah, I read it. I read most of it.
But yeah, it's a really, I'm actually rereading it right now because it's very complex. It's very well written, but there's a lot of, it was written, I think, a lot for medical professionals. Mm-hmm. So there is a lot of jargon, but there's a lot of that we can link to metabolic syndrome. They actually often call metabolic syndrome, which is like high triglycerides, a higher BMI, high blood pressure, just a group of symptoms that occur when insulin resistance starts to come up in people. And it's often nicknamed like oppression syndrome because it happens so frequently in marginalized groups of people. And there's a lot of studies there actually have been linked, like microaggressions towards Black women have been linked to CPTSD, like literally have changed their brain into what we see in PTSD patients just from living as a Black woman. Mm-hmm. So diabetes often connects to that because it's a disorder of inflammation. Stress causes a lot of inflammation. Being oppressed causes a lot of inflammation. We may also see this in the case of like women with diabetes have 3 to 4 times worse outcomes than men with diabetes. Pretty much mostly because it is an oppressed and marginalized group. Not just like being stressed out, but because there's no research on women to like, what are these hormones doing? How do they affect insulin? How are they? So we have no clue how that works. And then on top of that, you are experiencing misogyny in your day-to-day life. Yes, it's, and I have actually, again, I dated another guy with type 1 diabetes a while back, and I was so pissed off because he was just like having the time of his life. Again, not to say that he's not suffering or anything like that, but it was so interesting to see the differences in how our diabetes worked and all that jazz. Like most of the men I know only use multiple daily injections. Like they don't often feel the need for an insulin pump, whereas a lot of women use it because of or people with a uterus, if you're having hormonal cycles. So moral of the story is there definitely is quite a bit of things that we are linking to stress and trauma, and especially that of a person of color, where you experience that stress and trauma so much. That's why we see a lot of type 2 diabetes or insulin resistance.
Mm-hmm.
Lots of cortisol.
As we wrap up, could you maybe give us what are your final thoughts, your last words before we say bye to the people?
Yeah. Again, I'm sorry to those of you I have perhaps given information that's very intense and maybe something that you have not known before. But again, I hope that mostly ignites a little fire under you. And however that looks, whether you're talking to friends or family about it or supporting people that need to be supported within the diabetes community, that would be the most important thing to do, I think. But yeah, I have a lot of resources and posts on my social media about this kind of stuff, as well as very normal education topics. So it's a balance of education and dank, unhinged memes. But my Instagram is Give Me Some Sugar Diabetes. And then TikTok is Give Me Some Sugar Beaties without the diabetes, because I couldn't fit it. Yeah. Come say hi over there. That would be great.
Thank you, Rachel, for your time, for all the work that you do, and for being a very fun person to interview.